Okay, imagine feeling weak, like really weak. Not just tired from a workout, but like the connection, the very signal telling your muscles to move. Just isn't getting through. It's kind of what we're tackling today. We're doing a deep dive into neuromuscular junction disorders. This is basically where the nerve, the electrical signal, meets the muscle, that crucial handover point. And the problem, it's this chemical messenger, acetylcholine, or AC. Something goes wrong with its transmission right there at the synapse.
Exactly. That handover, it's incredibly precise.
Yeah.
And when it fails, we immediately think, okay, where did it break down? Three main spots.
Three spots.
Yeah. First, maybe the nerve ending itself, the presynaptic side, failed to actually release the AC package.
Okay, so the delivery person never sent it.
Right. Or second, maybe the AC was destroyed somehow in the gap, the synaptic cleft, before it reached the muscle.
Like the package got lost in transit.
And third, the muscle side, the postsynaptic membrane, maybe its receptors failed to, properly grab onto that AC
The
package.
recipient wasn't home, or the doorbell was broken.
Something like that. And understanding those three possibilities helps us sort through the big conditions we'll cover. Myasthenia gravis, or MG,
Okay.
Lambert-Eaton myasthenic syndrome, LMS, botulism, and organophosphate toxicity.
Right. So our mission today is really to make sense of these, focusing on what makes each one unique, the symptoms, the tests, because sometimes, especially with the toxic ones, figuring it out fast is absolutely critical.
It absolutely is, which brings us straight to the first, most vital step in any suspected case. The immediate threat. Airway first.
ABCDE assessment, always.
Always. You have to know if the patient is stable right now. Check their airway, breathing, circulation. If they're unstable, you stabilize immediately.
And the biggest danger here is what?
Respiratory failure. Plain and simple. The diaphragm is a muscle. If it gets too weak, they stop breathing effectively.
So they might need breathing support, like ventilation.
Definitely. Sometimes non-invasive positive pressure, like BiPAP, can work, but often they need intubation and mechanical ventilation.
That's a huge decision. How do clinicians know when to intubate? Is there a specific trigger?
There is. We rely heavily on bedside lung function tests. And there's a really useful clinical tool for this. It's called the 20-30-40 rule.
Okay, 20, 30, 40. Sounds important. Let's break that down.
It is. Gives you objective numbers in a critical moment. So the 20 refers to vital capacity, or VC.
That's the maximum amount of air you can blow out after taking a deep breath in.
Exactly. If that VC drops below 20 milliliters per kilogram of body weight, that's a serious warning sign.
Okay, less than 20, think trouble. What's 30?
30 is about maximal inspiratory pressure, MIP, sometimes called negative inspiratory force, or NIF. It measures how strongly they can suck air in.
Their inhalation strength.
Right. And if that pressure is less than 30 centimeters of water, that's warning sign number 2. They're struggling to generate enough force to breathe deeply.
Got it. VC less than 20, MIP less than 30, so 40 must be.
Maximal expiratory pressure, MEP, how forcefully they can push air out.
Like for coughing.
Precisely. Coughing, clear secretions. If their MEP is less than 40 centimeters of water, they likely can't cough effectively. Risk of aspiration, pneumonia, respiratory collapse.
Yeah.
It goes way up.
Wow, so 20, 30, 40, VC, MIP, MEP. That rule really gives clinicians a clear threshold for intervention.
It does. It helps make that critical decision to intubate before the patient completely fatigues.
Okay, so that covers the immediate crisis. What about the patient who isn't crashing, the one who comes into the clinic? You mentioned the typical story, painless weakness, maybe droopy eyelids, double vision, trouble swallowing or speaking.
Yep, the ocular and bulbar symptoms are classic. And the exam shows that weakness, maybe cranial nerve issues, weak neck, weak limbs.
But the absolute key finding you mentioned.
Normal sensory exam, they could feel touch, pain, temperature perfectly fine. It's purely a motor problem. And usually the basic labs, blood count, metabolic panel, muscle enzymes like CK, thyroid test, they all come back normal.
That normal sensation really narrows it down. Now, you said the next big split depends on whether the weakness fluctuates.
That's the crucial differentiator, especially between the two main autoimmune ones, MG and LEMS. Does the weakness change with activity or time of day?
Let's start with myasthenia gravis, MG. This one follows a pretty clear pattern, right?
Very clear. MG weakness gets noticeably worse with repeated muscle use. It's classically worse at the end of the day.
Like their battery just drains faster than it should.
Exactly. And it gets better with rest. True rest.
And you can actually see this on exam.
Oh, yeah. Ask them to look up for a minute or two. You'll often see the eyelids start to droop. That's atosis developing with sustained effort.
What else?
Have them count out loud to 50. Their voice might start strong but then fade. get quieter, more slurred dysarthria and hypophonia. Limb weakness is usually proximal, so shoulders and hips are weaker than hands and feet.
But the reflexes.
Deep tendon reflexes, DTRs, are typically normal in MG. That's another key point.
Well, there's a cool bedside test for MG involving ice.
The ice pack test. It's simple, but quite specific if positive. You just place an ice pack gently over the droopy eyelid for about 2 minutes.
And what happens?
Cold temperature actually inhibits the enzyme that breaks down acetylcholinesterase. So it allows the ACH that is released to hang around a bit longer and have more effect.
So the eyelid drooping gets better.
If the ptosis visibly improves after the ice, that's a positive test, strongly suggesting MG. It's a neat little window into the underlying physiology.
Because MG is fundamentally a problem with the ACA receptors on the muscle side, the postsynaptic side.
Exactly. It's autoimmune. The body makes antibodies against its own acetylcholine receptors, or sometimes against related proteins like MuSK or LRP4. These antibodies block or destroy the receptors.
Fewer working receptors means the signal transmission fails, especially with repeated attempts.
Precisely.
And if the antibody tests are negative or you need more confirmation, what about electrical tests?
Nerve conduction studies, NCS, are key. In MG, you see a decremental response.
Decremental, meaning?
Meaning if you stimulate the nerve repeatedly, the muscle's electrical response gets smaller and smaller with each pulse. Fatigue, electrically demonstrated.
Okay, and there's another test, SFMG.
Single fiber electromyography. It's more sensitive. It looks at the firing consistency of individual muscle fibers within the same motor unit. In MG, you see increased jitter.
Jitter, like they're not firing smoothly together.
Exactly. The timing between firings becomes irregular, asynchronous. It reflects the unstable neuromuscular transmission at individual junctions.
Okay, so MG postsynaptic, antibodies against receptors, weakness worse with use, normal reflexes, decremental response on NCS, improved by cold.
That's a great summary.
Now let's flip to the other fluctuating one.
Mm-hmm.
Lambert-Eaton myasthenic syndrome, or LEMS. This one behaves differently, almost the opposite.
It really does. With LEMS, the weakness often gets better with repeated use, at least initially. They might feel stiff or weak when they first start moving, but improve as they go.
So they sort of warm up.
Yeah, that's a good way to put it. And their worst weakness might actually be in the morning, improving as the day goes on.
Why the difference? What's the mechanism here?
LEMS is a presynaptic problem. The antibodies aren't attacking the muscle receptors. They're attacking voltage-gated calcium channels, VGCCs, on the nerve terminal.
Calcium channels. Those are needed to trigger the AC release, right?
Exactly. Calcium has to flow into the nerve ending to signal the AC vesicles to fuse and release their contents. LEMS antibodies block these calcium channels.
So less calcium gets in, less of AC gets out.
Right. The initial signal is weak, but with repeated nerve firing, like during exercise, some calcium does manage to build up inside the terminal. And that accumulated calcium eventually triggers more AC release, leading to that temporary improvement in strength.
Fascinating. A completely different reason for fluctuation. Now, LEMS often comes with other symptoms.
Yes, autonomic dysfunction is pretty common because those VGCCs are important elsewhere too. So dry mouth, dry eyes, constipations, sometimes erectile dysfunction or issues with sweating.
Okay, autonomic signs. But there's something else, something really critical associated with LEMS.
The cancer connection. This is vital. A significant percentage of LEMS cases, maybe around half or even more, are perineoplastic.
Meaning the LEMS is triggered by an underlying cancer.
Yes, most commonly small cell lung cancer. The cancer cells actually express those same VGCCs. The immune system attacks the cancer, but then mistakenly attacks the VGCCs at the nerve terminal too.
Wow. So diagnosing LEMS isn't just about the muscle weakness. It's potentially an early warning sign for cancer.
Absolutely. A LEMS diagnosis mandates a thorough cancer workup, especially looking for lung cancer.
Okay, so on exam for LEMS, we still see proximal weakness. What else is different from MG?
Besides the autonomic signs, like maybe orthostatic hypotension, the big difference is the reflexes. In LEMS, DTRs are typically decreased or even absent.
Because the initial signal getting to the muscle is too weak to trigger a good reflex?
Exactly.
And the electrical testing, NCS.
It also shows the opposite pattern to MG. After a brief period of strong muscle contraction, maybe 10 seconds, repetitive nerve stimulation shows an incremental response.
Incremental. So the muscle response gets bigger after exercise.
Yes. That brief exercise causes that presynaptic calcium buildup we talked about, leading to enhanced AC release and a larger muscle response temporarily.
Makes sense. How is LEMS treated?
Treatment involves meds to boost AC signaling, like pyridostigmine, which is also used in MG, or a drug called amifempridine phosphate, which specifically helps keep those VGCCs open longer. You also use immunotherapy, like IVIG or plasma exchange, to deal with the antibodies.
And crucially,
You treat the underlying cancer if one is found. That's often the most effective long-term strategy for the LEMS itself.
okay, that fluctuating weakness axis MG versus LEMS is super important. Postsynaptic fatigue versus presynaptic warm-up with big implications like the cancer link.
Definitely.
But now we need to shift gears. What about acute weakness that doesn't fluctuate like that, the toxic causes?
Right, botulism and organophosphate toxicity. These are emergencies, and the history of exposure becomes paramount. No waxing and waning here, usually just rapid onset.
Let's start with botulism, caused by a toxin from Clostridia bacteria. What's this toxin actually doing at the synapse?
The botulinum neurotoxin is incredibly specific. It targets proteins called snares right on the presynaptic nerve terminal.
Snares? What do they do?
Think of them as the docking machinery. They're essential for allowing the vesicles filled with AFT to fuse with the nerve membrane and release their contents. The botulinum toxin acts like molecular scissors,
Uh-oh.
and it cleaves these snare proteins. It cuts them.
So the ATMA vesicles can't dock and release.
Exactly. AT release is blocked, completely inhibited at the affected terminals.
Leading to paralysis. What does that look like clinically?
It's typically a descending paralysis. Weakness often starts in the face and eyes, double vision, droopy lids, difficulty swallowing, slurred speech, and then progresses downwards to the limbs and respiratory muscles.
How quickly does this happen?
Usually pretty fast. Symptoms often appear within, say, 12 to 36 hours after exposure to the toxin.
And exposure comes from?
The classic source is improperly home-canned foods, especially low-acid ones. But it can also come from contaminated wounds or sometimes injection drug use. And then there's infant botulism.
Right, the floppy baby syndrome.
Yes, caused by infants ingesting Clostridium botulinum spores, often from raw honey, which is why you never give honey to babies under 1 year old. The spores germinate in their gut and produce the toxin there.
Okay, so descending paralysis, recent exposure history. What are the key exam findings?
Besides the generalized weakness and potential respiratory failure, look for autonomic signs like orthostatic hypotension, and importantly, pupils are often dilated and poorly reactive to light. Flaccid muscle tone is common too.
Dilated pupils, that's different from what we'll see in the other toxicity, right?
Very different. Keep that pupil finding in mind.
Does the NCS testing help here, since it's also a presynaptic failure, like LEMS?
It can. Similar to LEMS, you might see an incremental response after exercise on NCS, because it's also a failure of H release, albeit via a different mechanism. Yeah. But you absolutely cannot wait for NCS results.
Why not?
Because treatment is urgent. Diagnosis is often clinical, based on that rapid onset, descending paralysis pattern, and exposure history. You need supportive care, especially respiratory support, and the crucial treatment is botulism antitoxin.
And you give that immediately?
Yes, as soon as you suspect botulism. Don't wait for lab confirmation of the toxin from stool or food samples. That takes too long. The antitoxin works best early, before the toxin binds irreversibly inside the nerve terminals. And remember, every suspected case needs to be reported to public health authorities immediately.
Okay, urgent antitoxin for botulism. Now the final condition, organophosphate toxicity. This is a completely different mechanism, right? Not blocking release, but too much signal.
Exactly the opposite problem. Organophosphates found in many pesticides and herbicides, and also in chemical nerve agents like sarin. They inhibit an enzyme called acetylcholinesterase, or ACE.
And ACE is the enzyme that normally breaks down acetylcholine in the synapse.
Precisely. Its job is to quickly clear HE out after it binds to the receptor, allowing the muscle to repolarize and be ready for the next signal. If you inhibit HE,
ACE just builds up and up in the synapse, constantly stimulating the receptors.
Exactly. You get a massive overstimulation, what we call a cholinergic crisis.
And the history here is usually pretty obvious. Exposure?
Often, yes. Agricultural workers, people handling pesticides without proper protection, or in rare, awful cases, chemical warfare exposure.
What does this cholinergic crisis look like? There's a mnemonic, right?
There is a very vivid one, SLUDG. It captures the muscarinic effects, the overstimulation of glands, and smooth muscle.
Okay, let's hear SLUDE.
S is for salivation, drooling. L for lacrimation, tearing. U for urination. D for defecation. G for GI distress, cramps, diarrhea. And E for emesis, vomiting.
Wow, that sounds messy and unpleasant.
It is. And beyond SLDGE, The nicotinic effects at the neuromuscular junction cause muscle fasciculations. Those are visible twitches under the skin, followed by weakness and eventually paralysis as the receptors become desensitized. Bronchospasm is also common, causing wheezing.
So SLEDGE plus muscle twitches and breathing problems. What are the key exam signs?
Profuse sweating, or diaphoresis, those muscle fasciculations.
Yeah.
And critically, remember the pupils in botulism were dilated. In organophosphate poisoning, they're usually constricted pinpoint pupils. That's meiosis.
Pinpoint pupils. Got it. What about heart rate and blood pressure?
They can be variable. Initially, you might see high blood pressure and fast heart rate due to nicotinic stimulation, but later muscarinic effects can dominate, causing low blood pressure and slow heart rate. It can be confusing.
Treatment must be rapid here, too. What's the approach?
Absolutely urgent. First, decontamination if possible. Then the pharmacological antidote has two parts. First, atropine.
Atropine blocks.
Atropine blocks the muscarinic receptors, helping to dry up those SLUGE secretions and stabilize heart rate and blood pressure. You often need large, repeated doses.
Okay, atropine for the muscarinic effects. But what about the ACE inhibition itself?
That's where the second drug comes in, pralidoxim, or 2PM. Pralidoxim is an oxime, and its job is to actually reactivate the acetylcholine esterase enzyme that the organophosphate has inhibited.
So it helps break down the excess AC again.
Yes, but it needs to be given relatively early before the bond between the organophosphate and the enzyme becomes permanent, a process called aging.
So atropine plus pralidoxim, fast.
And supportive care, especially airway management and ventilation, is critical.
Okay, so pulling this all together, we've covered quite a bit.
We really have. But if you remember those two main axes, it helps. First, the fluctuating weakness. Is it worse with use like MG, pointing to postsynaptic receptor problems? Or does it improve with use like LEMS, pointing presynaptically to calcium channels and making you think about cancer?
That's axis 1, and the second.
Axis 2 is the acute, non-fluctuating toxic causes. Botulism, presynaptic snare failure, no H release, descending paralysis, maybe dilated pupils, needing antitoxin fast, organophosphate poisoning, ache failure, massive H buildup, SLDGE and fasciculations, pinpoint pupils, needing atropine and pralidoxim now.
It really highlights how symptoms that seem similar on the surface, just muscle weakness, can stem from completely different breakdowns at that tiny junction.
Absolutely. And it underscores why understanding the mechanism is so vital, especially for those toxic exposures. You don't have time to wait for labs to confirm botulism, toxin, or cholinesterase levels.
You have to act based on the clinical picture, the history, and your understanding of how the synapse is failing.
Exactly. Knowing whether it's snare proteins being cut or an enzyme being blocked tells you immediately what antidote is needed. That mechanistic understanding, that ability to see the failure at the synapse in your mind's eye, that's often what makes a difference between a good outcome and a tragedy. It's not just what's wrong, but why.